So as you saw, the session will be recorded. Everyone will be on the mute mode except for the panelists. Next slide, please. My pleasure to welcome Professor Dr. Tufan Pati sir. He is from Cuttack. He is well known to all of us. And since he does not like his introduction to be read in full, sir, I am handing over to you to start the session. Tufan sir, you are in mute mode, I think. You have to unmute yourself.
So, thank you, Alim. So, I am going to introduce Dr. Amrit Patjoshi, who is our moderator. He is the professor of psychiatry in High Tech Medical College and consultant in Amri Hospital and Healing Touch Clinic. He is a direct council member of IPS and is the editor of Odisha Journal of Psychiatry, which is indexed. And he has been the chief coordinator of UNICEF WHO IPS initiative on telemedicine psychosocial management. He is now working hard for the suicide helpline. And yesterday he has inaugurated an oxygen tent in Bhubaneswar, which is very important. It will be a lot of help for all those working for it. And I take this opportunity to mention that, Amrit, and kudos to you. And we have with us Dr. Alim Siddiqui, who has come from Nawab Nagar, Lucknow, and Nawab by himself. And he's the director of Healthy Minds Neuropsychiatry and Behavioral Sciences Center. He's a visiting professor in Eras Lucknow Medical College Hospital and GHP Medical College Kanpur. He is a past direct council member, and he is finance secretary of IMA Lucknow branch and IAPP UP and UK chapter, taken together. Welcome, Alim and Dr. Amrit. And our chairpersons, Dr. Nimesh Desai, my old friend, very close friend. Dr. Desai is a psychiatrist and a qualified public health professional in public service academic career for nearly 40 years. Having served on faculty of NIMANS, Bangalore and AIMS Delhi. He has been at EVAS Delhi for 22 years and initially as the head of the department, psychiatry, medical and superintendent and then director since 2010 for last 11 years. He has nearly 100 research papers, many research monographs and has 5 national awards for original research. He works actively with NGOs and in community-based outreach program, including radio and TV. He is also with committees of and advisory panels of national agencies like NHRC, NDMA, NCW, ICMR, and others. He has worked with these agencies for mental health aspects since long and during the pandemic. And with us, Dr. M.L. Agrawal from Kota. He is an alumnus of Government Medical College, Patiala, Punjab, and the director for Agrawal Neuropsychiatry Center, Kota, Rajasthan. He is a senior consultant, ex-HOD of Psychiatry, MBS Hospital, Kota. He had been the president of Association of Industrial Psychiatry of India, president of IPS North Zone and Rajasthan state branches, Northern representative of IPS, and executive member of Association of Private Psychiatry of India. He has received Sir R.C. Hunter Award for his excellence in 2005 in Hong Kong and 2007 in Athens. He has received the Gayatri Gopal Award by the Association of Industrial Psychiatry. He has also received Aruna Madan Award for Mental Health Promotion by Community Approach by Association of Industrial Psychiatry of India. He is an international fellow of American Psychiatry Association. He has many national, international, state awards to his credit. He has special interest in community psychiatry, which is known to everyone. With this, I introduce and welcome Dr. M.L. Agrawal. And with this, I hand over the meeting to Dr. M.L. Agrawal and Dr. Nilesh Desai. Please carry on. Dr. Nimesh Desai and Dr. M.L. Agrawal, the stage is yours.
Yes, sir. Yes, sir. Thank you. If I might say on our behalf, both of us together, Dr. M.L. Agrawal and Dr. and myself, everyone, all of us know enough what task Dr. Tufan Pati, Dr. Amrit and Dr. Alim have been doing here every Thursday evening. And so I won't spend too much time on that, but really big thank you for having me here. Great job done. Like I said, Dr. Tufan and Dr. Tufan Pati said, we are not only old friends, we are long-time friends. So is true for Dr. ML and myself. Very briefly, Dr. ML Agrawal is an unbelievably energetic, locally popular, locally active psychiatrist in that region, that many of us may not realize. I've had the good fortune of having not only been to his home, but also his community outreach and awareness programs. ML, I wish I could say more, but I guess time constraints will save us. You want to say a few words before we
Thank you very much. Thank you.
Okay, okay. Let me say this, and allow me, Suresh and Dr. Tufan. I was recalling today that when I was doing my post-graduation in Ahmedabad, to my awareness was the first, if not the first major scientific publication on disaster and mental health. Dr. H.S. Narayanan from NIMHANS had published a paper in Indian Journal of Psychiatry on mental health aspects of circus fire tragedy. That was 1979. And then as a young faculty in NIMHANS in the 80s, I heard when they came back, Dr. Srinivas Murthy and Dr. Mohan Isaac, after having gone to Bhopal with Dr. B.B. Sethi and the others, to work on the psychosocial and mental health aspects of the Bhopal disaster. So that's how long back the track record goes. And then, of course, 93 was Latur that Mohan Agasha and people worked. From, I think, the beginning of this century, a lot of us got into that. Dr. Suresh Badaman, who is, I won't even say a rising star, he is already a risen star and a risen superstar that only can go higher. Worked a lot, I remember and know from his publications in Port Blair and other parts in Tsunami. And NIMHANS, IVAS, ICMR and other teams, Ministry of Health have had tremendous work in the Gujarat earthquake, tsunami, and after that. I'm sure Dr. Suresh Badamar is going to do more than justice to the topic. And so, ML, if you permit, shall we straight go on to Dr. Suresh? You want to say a few words?
We would like to introduce, Suresh.
Oh, yeah, I forgot. I thought, okay. Dr. Suresh Badamar is, okay, he's a PG diploma in human rights law. He's a PhD, a doctorate that very few of us are. And I make a very important differentiation in my mind between MD, which is a doctoral degree, with all respects to all of us, and a PhD doctorate. And so Dr. Suresh Badamar, besides being professor of psychiatry, in charge of the telemedicine unit, in charge of the forensic psychiatry unit, and a consultant in the community psychiatry unit, he is a PhD in law from the National Law School, Bangalore, and also visiting faculty there. More than 273 publications, a lot of awards. Most of us know Suresh very well. And so, Suresh Badamar, the floor is all yours, my friend.
Thank you, sir. Thank you, Agarwal, sir.
Yeah.
And I will share my screen. So can you give me the feedback? Is it if the screen share is available?
Yes, boss, visible.
Yes, Suresh.
Thank you, sir. Thank you. So, thank you. So this presentation, I'll be basically from my experience, what I have been worked in the disaster and also the articles which we have published, conflict of interest none. So that's the very fundamental important, because most of the presentation nowadays has been some conflict. So these are the two disaster where I personally volunteered to work. One is tsunami in 2004. As soon as I joined NIMHANS, I had an opportunity to go to Andaman Nicobar as the central government requested whoever is volunteered to go. So I was posted in Andaman Nicobar along with and also next the opportunity I got was in Uttarakhand. Other tragedies, basically disaster where my team was able to work. So this is a couple of pictures which we have taken personally, myself and Dr. Vivek Benegal, who was there. This is the photograph of a hut bay, and this is the Kachal, one of the island, which is almost remote part. Again, this is one of the school actually. And it was early morning Sunday when the tsunami hit. Since the school was closed, so no major problem. This is the team which landed on January 2nd. This is the multidisciplinary team. Dr. Satish Grimaji, current director of NIMHANS, was leading the team. I was along with the team, along with psychiatric social work team. That is GS Uday Kumar sir was there, but he is no more now. And the psychology and also the psychiatry team, the whole team ended. And this is, my whole presentation is based on this article, which was published in Indian Journal of Psychological Medicine in 2015. So what is disaster? So is it the bus accident, or there is a train accident or a terrorist attack? What is disaster? Or is it like floods? Is it disaster? So the defining disaster is a big problem. So hence various country have decided or defined disaster in various way. And the Disaster Management Act of 2005 defines like this, but one common phenomena is behind the coping capacity of the people affected in the community. So these are the commonalities which are seen in almost all definitions. It should be sudden in onset, unpredictable, uncontrollable, huge magnitude of destruction, human loss and suffering should be there, and also greatly exceeding the coping capacity. If you look at any definition across the world, these are the commonalities we've seen. Here and there will be some changes with regard to definition of disaster. So next question is, what is the principle behind the disaster management or disaster mental health? So earlier it had a different connotation, but now it has been focused on preventive medicine. That is basically what we talk about, community medicine, from relief-centered post-disaster to preventive-based. So it has 6 R's: readiness, being prepared for the disaster, immediately responding, relief, immediately the relief, sustained relief work should occur, rehabilitation, recovery, and resilience. So these are the 6 R's which have been advocated across the world with regard to disaster management. So what are the different phases of disaster which we see across the world? So there are 4 important phases: heroic phase, honeymoon phase, disillusionment phase, and restoration phase. So we will discuss those in a smaller, as soon as the disaster strikes. This is I am taking from tsunami and also to some extent from Uttarakhand, where the disaster strikes. And on x-axis, you can see the duration, and on the y-axis, it is the emotions. As soon as the tsunami occurred, there was a heroic phase. The people tried to save each other. The people were able to donate the whatever belongings they had, even the food, all those things happened. And here in tsunami, it lasted for 1 week. The reason being is the relief material which had to go to Campbell Bay, that is almost from Chennai or else Orissa or else Calcutta. From there, Vishakhapatnam to Port Blair, from Port Blair to Car Nicobar Island and Campbell Bay. It took, even a ship takes at least 5 to 6 days. And our team, Dr. John P. John, Dr. Vivek Benegal, even Rajesh Sagar sir was there. We were there. We had even worked in Campbell Bay. The team, Niman's team was there for 6 months. So to reach by ship is around 1 week. So heroic phase lasted for 1 week. Many people had to be there without any much help because these islands are very small. There is no, what we call it as the flight availability. It's helicopter has to go, and the relief material used to be sent was very less. But after 1 week, the relief material started coming in, and the amount of work which occurred at that time was phenomenal. And that's heroic phase lasted for 1 week. And after 1 week, the honeymoon phase starts. This is called as honeymoon phase because the people were shifted to various camps. They were brought to Port Blair. In Port Blair, various schools were converted into camps. The stadiums were converted into the camps. And here, the various ministers, politicians will come and give talks that I will do this, we will do this, and even the bureaucrats will come. So this is the time that honeymoon phase lasts. That's where a lot of promises are made, and they will say, we will give this relief material, this is the amount. All promises occurs in honeymoon phase. Once the honeymoon phase, which lasts after 2 months, it goes into disillusionment phase. Here the reality hits. Example I can give you. See, what happened was in honeymoon phase, the many people promised and they said at that time that we will give you 1 lakh immediately for family. Okay, 1 lakh. But the problem is you have to show the documentation for that this is a family. And in tsunami, everything was swept. So there is no documentation. They don't have, you imagine in 2004, there was no Aadhaar card. So how to show the documentation? Without documentation, money will not be released. Okay, by the word of mouth they gave. Now, in a family, the brother and sister, 2 brothers are there, but 1 brother died, and that family is along with the another. So now they can't say that there is 2 families. It's so problematic was there. So even disbursing the relief material or relief money was very difficult. So that's where the disillusionment phase starts, and the reality hits. And then the camp starts. What they're removing, the camps will be removed because they cannot sustain for longer duration. So that's where that's where the problem starts. Psychiatric problems comes in, and exactly 1 year there will be anniversary reaction, and usually it lasts for 2 to 3 years. and then the restoration phase occurs. This is how the emotions and the phases of disaster, and invariably a society, a community to bounce back, it will be at least 2 to 3 years. So now we have talked about physical disaster. We are going through a biological disaster, which is the COVID. Is it any difference? Can it be? Yes, it is a disaster. That is the reason National Disaster Management Authority Act has been pressed. So in this, again, there are phases, but they are slightly different from the physical disaster. Phase 1 is no human infection. Phase 2, there is a jumping from, most probably from animal to human infection. Third will be so sporadic. Fourth is the community level break. That's where the problem starts, community fourth. So that's where the heroic phase, or else you can call it as honeymoon phase. Phase 5 will be 1 or 2 countries. 6 will be the pandemic. And the 7th phase will be considering is wave 1 or second wave, third wave, that is the subsequent waves. The last is post-pandemic period. If we superimpose both physical disaster and biological disaster, this is how it looks. We are now in the phase 6, that is the second wave. So we are in the disillusionment phase. Basically, we are going to see a lot of mental health problems at this period. And if we are going to have a third or fourth waves, we are going to see more. So this is where our active intervention is required, not in the heroic phase and honeymoon phase. I'll come to shortly about this heroic and honeymoon phase, what are the problems we are going to see, and even in the restoration phase. So what are the normal human response? The normal human response is basically the survivors, all survivors are normal people in abnormal situation. That means every loss has some grief. That's we have to keep in mind. So normal people in abnormal situation, that is the very important. We should not pathologize all problems as mental health problems. So normal reaction is, for any loss, there is a grief. That we have to be very clear. That is normal. The problem comes is abnormal reaction. And currently in the pandemic, we do not have that grieving process. Earlier, whenever there is a death, family used to get together. There is a ritual carried out. People will come, they will do the ritual, and then the grief resolution occurs. But the problem in this pandemic is the dead body is not given to the people, that is the family members. And even if they are coming, there is a restriction. The grieving doesn't occur much. And the people have their own problems, like I may get infected. The whole family is in the anxiety. So, and even sometimes what happens is the family member, the father, say son or the daughter, may not be able to help the mother. Then the survivor guilt. So my dad died and I am not able to help them, or my mother died, I am unable to help them. So that kind of unresolved grief is going to be more over a period of time. I think we have to be prepared to handle those grief, because we are not able to have the grief. The same thing happened even in tsunami. The bodies were not found because the people were missing in the ocean. Even in Uttarakhand, the flood, that Himalayan tsunami, what we called, there also the people were missing. Then there was a symbolic ritual was carried out by the government and the people and the NGO. If they were not available after over a period of 1 to 2 months, they said they are missing or they are died. So we will have a mass ritual that was carried out to have a closure, because every human being want to have a closure, one, and want to know the reason why me. That is the problem in the every grief situation. So with this, again, this is one of the article which was been published in the PTSD book by the DJ Stein. And this is again from the from our DRDO group there, this one. So every survivor's experience to disaster is unique. That means the disaster is common. It is an abnormal situation, but every survivor's experience is unique. So what is the prevalence of mental health morbidity in disaster affected population? There are many studies, but I am quoting from the whatever available in Indian literature. So we can categorize into acute phase and long-term phase. Acute phase is basically less than 3 months, and long-term phase is more than 3 months. This is just a category which we have considered so that how we can intervene. So in acute phase, most of the time it is self-limiting. Invariably, if we had seen in tsunami, we are going to see more of dizziness, somatic complaints, and insomnia. Those are the kinds, and acute substance withdrawal. These are the commonest symptoms we see in acute phase. So, and also many a time In the children, we are going to see school, if the school opening is their school refusal, clinging behavior, not moving away from the parents, and bedwetting, milestone regression occurs, non-specific symptoms. These are the symptoms which we are going to see in children. So what are the people who are risk in developing mental health morbidity? Depends upon three factors. One is disaster factor, human factor, and social factor. Disaster factor is severity of the disaster, threat to the life, duration of exposure to the disaster, loss of family members. So that is the disaster factor related. That means they are the high risk of developing mental health morbidity. Human factors are female gender, children, elderly, physically disabled, chronic medical condition, substance use, poor family support. So these are the human factors which contributes to the development of mental health morbidity. Social factors are loss of economic livelihood, poverty, poor socio-economic support, ethnic minority, and displaced population. See here, the displaced population has been found to be common in most of the disaster. Wherever you move the population from the area of disaster to new place. For example, in tsunami, many populations were removed from their island to Port Blair. So they had maximum, I'll come to that publication, they had maximum mental health morbidity than the people who were not removed from the original locality. So coming to resilience. So again, most of the studies are focused on pathology. That means what is mental health morbidity? For example, if we want to do study in PTSD in current pandemic, everybody will be looking how many have mental health morbidity, but we don't look at who are the people who are resilient, why they did not develop mental illness, why they are able to cope. Those are the things we are not done it. But invariably, the indirect factors what we got from the Andaman Nicobar, this one was maybe genetic factors, developmental factors, childhood insult to the brain. These are the things which substance use, presence of physical and mental illness, these are the resilience. But supportive factors is cohesive community, sharing of community resources, minimal displacement, good social support, good family support, altruistic behavior from the people. So these are the various factors. But again, still now we are unable to focus on which resilient factor is the robust finding which is going to predict that they will not develop mental illness. Those still we are unable to focus. Coming to, suppose you are a part of a disaster team, what you should do? Suppose you go to any place, do not expect VIP treatment. If you are, suppose you are going to any disaster hit area, invariably what happens is, oh, I am a psychiatrist, I am a professor. Do not have this. If you are having this syndrome, don't go to the disaster area. Be ready to sleep anywhere you want. Anywhere it is available. If you ask me, in one of the island, we were sleeping under the tree. In some of the houses which were almost broken, in tsunami, we had that aftershocks because of the earthquake. Anytime that can fall down, you cannot expect, give me this hotel. No, it is not available. So be ready to work because you are going to a disaster area where already resources are meager. So do not strain on that. You go there as a volunteer, be ready to be in under any circumstances. We used to get one meal a day. Be ready for that. Don't say that, oh, I'm not getting meal. Otherwise, don't go to the disaster work. So you have to be ready for that. And first and the foremost, what we did was, as soon as we got down, either even in Andaman Nicobar, that is in Port Blair, or even in from Dehradun, when we went to Joshimath, Badrinath, where Dr. K. Shekhar and we were posted there, and Dr. Naveen and the team were posted into the Kedarnath Ghati. From there, he went towards the Gomukh. So Dr. Naveen was that side. So we were able to do initial assessment, submit the report. So the need assessment was done in the hospitals, then going to various camps, and they're talking to various people, looking into what is the mental health resources available, how many psychiatrists are there, how many psychologists are there, whether the medicines are made available, whether the medicines are not there, how many people are sensitized, whether they know how to provide mental health care, psychological first aid. So these are the needs assessment has to be done. So for that, it may be rapid assessment has to be done so that what can be sent or not, because the early phase, heroic phase and honeymoon phase, that is the time we have to do the rapid assessment so that we can do the deployment during the third phase, that is the disillusionment phase. Moving, this is how we, again, you cannot expect to find a room for do counseling. No, the relief work occurs in open air. It's like this. They will give you a chair, they will give you a table, and wherever it is possible, start working. That is the way it is. You cannot say that, no, this will not happen. Here, you can see Dr. Uday Kumar, that is a psychiatric social work consultant. He was giving medicine because you have to have task shifting there. No, this person will do this. No, that is not going to happen. Task shifting is very essential here. And he was giving medicine. Somebody was doing screening, and psychologists at that time were doing even BP assessment, doing BP. You can see that. So you have to be flexible and you have to be ready to do any kind of job. And as soon as you are doing the camp, there will be relief material coming to the camp. Suddenly, all relief people will move to somewhere else. So you have to withhold the camp, medical camp, wait for the relief material disbursement, then they will come back. And whenever you have to give, telling that I am available, you have to use public announcement system in the camps. They will be made available usually. You can announce so-and-so doctor is available, and you can give them, then they will be able to come to seek help. But again, you should not announce telling that psychiatrist doctor is available, mental health camp is available. If you say, nobody will come. You have to use somatic complaint method. You have to announce telling that today doctors are available from Delhi or Bangalore. Whoever has a child who has clinging behavior, crying, not sleeping, there is a dizziness. And still, I remember one of our social work team member psychiatric social work team member used to go there and announce telling that जिसको भी खांसी है, जिसको भी सर दर्द है, जिसको भी चक्कर आती है, जिसको भी problem है, वो आ जाइए. Then you will get maximum people coming. If you say whoever has mental illness, please come, no person will come. You will be sitting there without doing any work. So you have to demedicalize, deprofessionalize your services. Task shifting should be the plan, and then you have to use somatic complaint related way, and you have to talk like panic attacks, जिसको भी दिल का धड़कन तेज हो रहा है, नींद नहीं आ रहा है, जिसको चक्कर आती है, इस तरह का अगर if you are able to give this kind of phenomena, people will come, then you can screen. So that is the way to go. Otherwise, if you say you have mental health problem, you have psychiatric problem, please come, nobody will come. So that's again, this is one of the publication we have published in the International Review of Psychiatry. And again, next one is providing services in the camp. Second one is advocacy and capacity building. Here again, our team, one of the team member used to go to various colleges, schools, talk to the school authorities, awareness training program, educational. And one of the best thing what we did was in Tsunami and also in the Uttarakhand, we liaised with various educational department, going and meeting them, talking to them and asking them to dismantle the camps so that the schools can be started. That means children need to be as early as possible. We have to normalize their activities, sensitize ASHA workers, Anganwadi workers. And another important thing which occurred in Tsunami was talking to the electricity department. The reason is all these islands, the electricity generation occurs through the diesel, which are situated on the seashore. When the tsunami hit, the electricity department people died. Around exactly, I don't know, 60 to 70 people who are working on that day in the early morning of Sunday, they died. So the electricity department gave an invitation to us that you have to come do the counseling to the family members. So we had our own team. We're sitting and talking. See, you can see there is a family sitting there. The male member of the family is missing. He is no more. Father and mother is there. Wife, 2 children are there. So this kind of activity has to be started. What is their needs? And communicate, telling that this is the requirement. That is the psychosocial assessment. You will not be doing mental health assessment. Psychosocial assessment here, telling what is the family needs, what has to be done. In Uttarakhand, we said that the families lost their all belongings. We had to request the government, telling that please waiver off this year's fees for the school. That was taken seriously at that time by the government, and they waived off the fees. So these are the assessments, and has to be given back, feedback has to be given. Even I remember the Desi Raju sir was the health secretary for Uttarakhand. We went, met him, did the presentation. Dr. K. Shekhar did the presentation, and it was said that there is no DMHP in Uttarakhand. Immediately it was taken seriously. Now DMHP is functioning in almost all 18 of the districts now, and it was taken on the war footing. So when you give the feedback, it will be taken up very seriously. And disaster is the time you can revamp the health system. It is an opportunity. It is a disaster, but it is an opportunity to revamp the health system. Again, in COVID, this is the time to revamp the public health system. Obviously, it should have not occurred, but it is an opportunity. So similarly, these are the we went to various schools, training, sensitizing the school teachers, telling them how to identify children who are going to have problem and referring. This is one of the Asian Journal of Psychiatry we had published. And one more important thing is never criticize disaster relief work in the ground zero situation. This happened very badly in one of the island. One of the doctor from other central government came, and there was food was not available, went and shouted at the administration. The problem is administration is already disaster affected. They have lost their family, and their houses have gone into the tsunami waves. This person who has gone as a volunteer there to work shouts, telling that I am not getting food, I am not getting this one, this is the way you look after people who have come. He shouted in front of his family to a senior administrator. Senior administrator was so angry, he wanted to hit him. It became a problem to do relief work. This was one group, because this whoever created trouble criticizing created a mass against the administration, which was unwanted at that period of relief work. So never criticize disaster relief work when it is occurring at the ground zero. I'll give an example. Sorry to say this. Suppose in Orissa there is a cyclone, okay, and the administration is running around doing all those things. I go as a relief work person to disaster, and I go there and I don't get some food or something. I start abusing everybody there. Already the community is going through a disaster. I go and making noise, shouting at them. It is unwanted. Never do that, because whoever is the administration NGO, they themselves are going through a tough situation. Please never do. If you want to work with them, go. Otherwise, don't go there and create trouble. And many people go there to create trouble. Please don't do that. Ground zero situation, unless if you want to do a constructive criticism without criticizing, you have to make correction so that the administration who is under tremendous stress should be able to take positively and do it. And when you go to the camps, know the distribution of the camps, because invariably the administration divides the camp into such way, this camp will be by this community, this camp will be from this area, this camp will be belonging to this, male will be in this side of the camp, or this kind of division occurs. You should be aware of this. Talk to the camp administrator, whoever is in charge, talk to the camp doctor, and then enter into the camp. Just don't jump into the camp and start working, because you will make mistakes and the people inside the camp will think you are an outsider. It will again create a problem. At the same time, know which camp will be disintegrated today. So don't go to that side. You have to know how the repatriation of the survivors or the refugees occurs. You should be very clear. At the time, displacement of the survivors from the habitat should be kept in mind when they will be sent, connecting them, and psychological first aid has to be planned in hand. Working with high risk population is very essential, because many a time everybody is affected. You don't know how to start, where to work. Best is to contact the high risk population, displaced population, maybe ethnic minority, or else the people where the maximum problem, like we got a information, Car Nicobar group of people who have been seriously affected has been shifted to this camp. We went there, we found maximum mental health morbidity. Where there was affected was only property. When we went there, the mental health morbidity was less. So again, this is again one of the study where we have published, where we about displaced population had higher morbidity than the non-displaced population. So this is again, we were working in Dr. Rupesh BN, again from our clinical psychology department. We started working with the children. How to start? We started giving just a pen and paper, asking them to draw something. So first day is more of informal. Second day, we start discussing, can you do a diagram what you saw on that day? After 3 or 4th session, you ask them. So they start writing about their experience. This is a young boy who saw their family members and friends swept away in the water. So this is a beautiful diagram. He showed how the trees were uprooted. And again, you can see the photograph where the flash floods took away his friends. And here is again from the earlier Campbell Bay. Here again, where the whole medical college, medical camp, PHC, school, everything was destroyed. Ambulance was uprooted. There was no structure, actually, if you ask me. There was no medical hospital was not there. Schools were not there. The complete reformation of the community has to occur in an island. So the whole people were running. This was the diagram done by one of the child, which was around 12-year-old. This is 6-year-old child has seen. She saw dead bodies floating in the water. So, and she said, I am here, I am running towards my mom. My mom had been gone there. And so this is how the children will start narrating, showing the diagram. And this is how we can do some of the work. So this is the publication we have done with regard to psychological impact of tsunami. This is through artwork. Again, even in the Uttarakhand, similar kind of activity was done, and also involving children. And the gender difference is another major. This was the article which we got the award. And this is again working with the geriatric population. Here, both the elderly population, the whole son and his family died. So both the lady, the grandmother and the person felt that why are we alive when my son and my daughter-in-law should be alive? The survivor guilt was very huge for them. The God should have taken us, not them. So this kind of work we should start working them, because the survivor guilt is one which will be a problem. Though survivor guilt, again, one of the other classical example we saw was in the camp, a elderly man, a young boy means he is around 23. His wife died, his child died. He survived, and he had a severe guilt telling that I could not save my child and my wife. He was drinking very heavily. After drinking, he used to create trouble inside the camp, because what happened was the relief money was given. That money was utilized to buy alcohol. The reason was guilt. And when we talked to him, why are you drinking? What is the point in leaving? Because my wife died, my child died, and I could not save them. That survivor guilt and validation has to be done. So these kinds of activity has to be carried out. This is the psychological impact of tsunami survivors in the elderly population. And till now, one of the best example I can give you is one lady who was working in, I think in one of the Chennai. During tsunami, she was here. She came to study against the family wish to study in Chennai. And the tsunami occurred. After tsunami, she went in search of her family. Her family, around 13 members, none of them were available. For nearly 1 month, she searched, she was not, but she was working in the camp as a volunteer. And there was not even a single day she cried. That's what the people, her friends said. And no family members, no evidence they are alive for nearly 1 month. She did not cry. So they said,
अरे वापस ज्वाइन करना पड़ेगा इसको.
I think so. His connection has dropped out.
yeah, hello, I'm joined back. Can you see the slides?
No slides.
Yes, sir. Now you can see it.
Okay.
Sorry, so yeah, coming back to the she did not even had any grief. So first time our team started talking to her, she was in complete denial. And then when we said most of the people would have died if we don't know after 1 month, then she broke down. It was very difficult to control, because it was a kind of what we call it as the grief. When it started, we had the two of our health workers have to sit there and see the way she had a complete dissociative attack kind of crying. It was very difficult to, acute stress reaction was there. So this is the disaster management, how your plan is preventive. And coming to the management now, what is the way we can do as a professional? The question is there a role of psychiatrist and mental health professional in disaster relief work? Of course, before the disaster strike, it is preventive work. After the disaster work also, till the honeymoon phase, it is the preventive and plan, and the disillusionment phase is the curative work starts. And another one is the stress management. So these are the areas where before it strikes. So during pre-disaster, basically public health education, disaster response training materials, and developing a network of doctors the way we planned, psychoeducation, community level support, informal education, IEC activities, those kind of things done. In the heroic phase and honeymoon phase, this is the time we have to provide medicines who had pre-existing mental illness, because they are the one who are going to relapse at this time because of stress. Though it is an heroic phase and the honeymoon phase, if we don't provide medicine, not only for mental health, even for physical health, they may not have diabetes medicine, they may not have hypertensive medicine. So that is the issue. So there you have to, being a part of multidisciplinary team, you can't say I'm only psychiatrist, I will be doing psychiatry work. No, you have to start working. Even if you have to do a lot of other work, like even carrying the dead body, should be able to do it, because you can't say I'm elite, I'm MD psychiatry, I'll not know. If you have gone as a relief work volunteer, whatever work is there on that day, please do it. And whenever you get an opportunity to do mental health, please do that. If you get an opportunity to do first aid, please do that. Physical first aid, psychological first aid, that has to be done. And the outreach team has to be planned so that they move from one camp to another camp. That is the way to go ahead. And also fostering the mass grieving process, mental health education, utilizing the mass media. This is again one of the way to contact newspaper, give simple messages telling that these are the ABCD to be done. So many a time, keep a printed material which can be given. That's what we planned in Uttarakhand. We had an opportunity to, because when we were working in one of the relief camp, we came to know that there is a health minister is coming. Immediately we jumped in, went ahead and gave the relief relief related pamphlet, what is NIMANS is doing, what has to be done for the relief. Immediately he took it and he said, sir, can you call me in the evening? So we were able to talk to them. So that kind of immediately networking has to be done. So collaborating with people, find NGOs, planning research if possible, that should be planned in the heroic and honeymoon phase. Coming to the curative phase, again, here is the providing plan for rapid screening and treatment, capacity building activities, training of resourceful community workers, a range of community workers you should be planning. Don't have this myth only psychiatrists will treat. That is, in disaster, you can't do that. You have to do task shifting, allow even MBBS doctor to give medicine. If possible, even many of my friends who are sitting here may not agree, we have to go ahead with paramedical staffs. Let me tell you, even in Uttarakhand, in Badrinath, no doctor was there when we reached there. If we were Dr. K. Shekhar, we were there. There was no doctor. The pharmacist was giving medicine. And we started taking up the PHC, we started working. So, keeping in this utopian model, only psychiatrist will treat, only clinical psychologist will treat, only psychiatric social work, that is myth. It is not available. When the disaster strikes, you can find a problem one after the other there, and you will not be able to expect what will happen next moment. So it can be violence, it can be, because it's a very volatile situation. Best example I can give you is again in Badrinath, almost 25,000 pilgrims were stuck there. And then what they did was the temple committee said that we will give because see, 25,000 people stuck there, that means they have to be removed from that place. There is no road. So they have to be moved from the helicopter. So how many helicopters you can send? One helicopter can carry 4 people. And if it is a military one, it will be, a chopper will carry something around 10 to 15 or maximum 20. So how many, if the environment and the weather is good, they'll be able to do sorties one after the other. If it is not there, that means that day they will be able to do 1,000, maximum 2,000. So it will run for 25 to 30 days sorties. So that means who will go first? That seniority has to be done. So temple committee formed the seniority list. And then there was some problem. They started fighting. The administration made one list. There were 2 lists now. The one list which for 25,000 people, another list for under 25,000, they started clashing each other. Mine is first, I was this. Then finally the army and the Air Force came and said, we will not consider all those. We are the one we are evacuating. NDRF took over. NDRF said that we will form a list, and the list finally was theirs. So these kinds of chaos will be there. The chaos will be to that level you can't imagine. So you have to be very flexible, start working. Don't, you are gone to help, not to create trouble. That is very essential, because it is easy to make noise there and create trouble, but working, helping each other is very essential. So feedback mechanism. And if you ask me at that time, the way the army did, the army, navy, and the Air Force people did was amazing work. The sudden, once they took over, they said nothing doing, this is the way, morning, this time the seniority will start, and who will give the, again, some doctors who were there, they were giving some letter telling that this person is very sick, has to be evacuated. Then our team came, then they said, even if you write, the army doctor will verify it. And then the priority basis evacuation started. So all those we have to keep in mind and start working. So this is how the disaster management work. And this is again summarizing the preventive work of all the, like first aid, basic counseling, grief, trauma work. All you have to be ready to do all one. And finally coming to taking care of the team. If you go as a team, have a debriefing every evening, start writing the diary, carry required medicine. Because writing diary is very essential. Simple reason is you don't remember what happened 3 days back. You don't know what is today. In like the way it is in COVID now. You don't know if today is Saturday or Monday or Thursday. Because there is today is Thursday musing, you remember. Otherwise, you don't know what is which day. That's the reason you have to keep diary, date, time, what has happened. And this is the evening we used to sit together and discuss what has happened today. What was my emotional problem by looking at some problems, discuss, and cognitive restructuring of our own team members is very essential. And another one is health of the team members should be to the top notch. You should not take a team member who has health problems, and they should be ready to walk. In disaster, myself and Dr. Rupesh Bian were able to walk from Badrinath to Joshimath. It is around 35 kilometers. They said, we will take you to the Badrinath to work, because when the chopper goes to Badrinath, it is empty. So they took us. When they came, when it is coming back, they said, we will not guarantee you how will you bring back. You find your way. You are a healthy person, you are a doctor. So what we did was, we moved from Badrinath to next Hanuman Chetty, worked there in PHC, stayed in the night, next another village, walk, work there, find, make a report, move to another village. So this is again, you have to carry your own luggage, and in the places you have to walk, you should be able to walk. And one of the person had a severe problem because his health broke down. Looking after him was a problem, and sending him back is another problem. So health of the team member should be at the best. So like Dr. Amrut, who is very fit, should be able to work. The other person who has should not, because you have to move from one place to another. Be flexible, be ready for unexpected. There will be a call in the night telling that there is a problem, you have to move there, you should be there. And whenever you get time, take a break and use pamphlets, psychoeducation material, be sensitive. And whenever in the disaster area, there will be some medias who would like to take opportunity. Be aware when you are interacting with media, give pre-printed material, and don't disengage, but engage the media in a responsible way. This is again where we are able to talk to the local media, and then they were able to publish. And carrying out research is a big difficulty in disaster area. Wherever we have worked, either it in Uttarakhand or even in tsunami, we were able to work up to 6 months. After that, carrying out the research work is very difficult, because we have our own responsibility in the primary institute where we work. And this is again the June 2015 we have done. So this is like last part. What is the role of medication in disaster management? The role of medication is only for pre-existing mental illness and substance withdrawal. And if you find new cases, depression, PTSD, anxiety disorder, that's the only thing. You cannot give prophylactic fluoxetine to everyone. No prophylaxis, only pre-existing mental illness. Newly diagnosed cases, you will give medicine. Otherwise, the role of medicine at this point of time, there is no study, because we have done this review. I had an opportunity to work with Rachel Ferguson. She is a American Psychiatry Association working with regarding to PTSD and trauma. We did the review. This is available. There is no evidence for psychopharmacology medication as a prophylaxis to prevent depression or PTSD in disaster area. So this is the no justification is available. But however, non-pharmacological intervention like psychological first aid, trauma-focused CBT, critical incident debriefing, plus or minus, currently the evidence is available, EMDR again plus or minus, stress management, yes, for the relief workers, community-based group intervention, various art therapy, group discussion, yoga, those are the things which can be considered, but medication for prophylaxis, simply no. So to finally demedicalize, deprofessionalize when you work in disaster. So psychological first aid, take home message, last slide. These are normal people in abnormal situation. Health of the team member is very crucial. Don't carry VIP syndrome into disaster area. And disaster health workers need to be remembered for basically the primary reason to enter disaster zone is because you are going as a voluntary. So don't have that VIP syndrome. Thank you very much for giving your valuable time. Sorry for there was a technical break. Over to the chairperson.
Thank you, Dr. Suresh, for the wonderful presentation and salute to your practical work. I would like to one question from you.
Sir.
I am continuously treating the patient in this pandemic, but I observed myself in second phase, patients immediately after recovery from the COVID, they are suffering with psychotic symptoms more. More cases are coming right from the ICU. We were getting the calls from the ICU, and not in the first phase. In second phase, I observed this thing. What about your opinion, others' opinion?
Sir, with regard to currently after coming from the ICU, psychotic symptoms, basically we are finding it organic problem because it may be because of the thromboembolism phenomena or various sudden. Sir, actually, if you ask me, I don't know the answer, sir. Let me be very frank. I don't know the answer.
I'll tell you.
Trying to make it. Yes, sir. Please, sir.
See, the thing, ML, is that like Suresh explained so well, but let's recap that one or two more times. He did emphasize that. First thing, in the disaster field situation, A, B, in the secondary or tertiary healthcare centers, especially mental health care centers in that region or in that state, there is going to be the highest number of recurrence and relapse cases. See, one of the things that we established in an ISMR project in tsunami with Dr. Nambi and others was very interesting. And we established it in Gunjal earthquake also. What happens is that the state governments, with all respect to state governments and central governments, tend to rush experts to the field. Okay, they live in the tents, and the flow of the recurrence and relapse cases is towards the hospital centers. And so this is what I have called in that report the reverse flow of expertise. Okay, which is very sad. Now, hopefully, as I participate in the mainstream meeting sometimes, hopefully this is getting better. Like Suresh said, let's remain at the back, do minimal work, empower them. If you are talking about the current epidemic and the ICU.
No, not ICU. No.
I get
Listen, Dr. Desai, I treated in the first phase also. Now I am treating in the second phase also. Patient from, I'm not talking from the ICU. After post-recovery, in post-recovery phase, there are number of new patients, not recurrence. Number of new patients are coming.
Correct, ML. Correct. Yeah. Let me clarify that.
No organic symptoms. Organicity already ruled out in all cases.
There are two or three aspects to that. Yeah. One is we all know about the ICU syndrome, especially in this pandemic. The ICU syndrome in the second wave is obviously terrible. Okay, yeah. So one is that. Second, the trauma of that near-death experience or the ventilation that you went through or all the anxieties that you went through. So I'm totally with Suresh when he says that there's too much evidence from the disasters that I'm sure this epidemic will confirm. Acute stress disorder are much more common than any other endogenous psychiatric disorder. So essentially what you are talking about, the second wave ML, is, to
Yeah.
my mind, the acute stress disorder combined with the ICU problems of the second wave.
I am sharing, we should think on this line.
Sure, absolutely, sir. And
Yeah.
I'm again totally with Suresh when he says that all that the persons require is psychological first aid, supportive counseling,
Yeah,
maybe
that
trauma-based CBT, and most importantly, group interventions, if we can still do. I don't know if any one of us here would be able to share. I haven't heard, even in last 14 months, many attempts at group methods in the current pandemic. Now, beyond, after the second wave, it seems to me, Suresh and ML and other friends, we really need to work on group methods with the numbers that we deal with. Hello, sir.
Most of
But let me
cases,
also try and see if there are questions in the chat. I noticed there are a lot of questions in the chat for Suresh and otherwise.
or I am not talking of the mild cases. I am talking of the
I know,
cases
sir. Sure.
brought by after tying the after rope with rope they brought to. I am talking patient needs admission. Such patients, very
Correct,
violent
sir,
patients.
correct.
Yeah. Okay.
Suresh, there is a question. What is one thing that you remember?
Sir, one carry home message what I learned from tsunami is one of the best is we call those people who are in the islands as a tribal people, especially Nicobar, but they have an amazing cohesion. And when we went to work in Nicobar Islands, this is the classical, we are so-called islanders here in India, basically islander. We are all mainlanders, they are islanders. We call them as tribals. We are civilized. But what happens, I'll give you best example. Still, we went to Kachali when Dr. Vivek Benegal was with us. Here, the relief material truck comes, okay, it is an island. This side is the tribal group. This side is so-called civilized people who have gone from mainland India, from Chennai, from Orissa, from Kolkata. They are settled, Bengali, all people are there, including Kannadigas, Andhra people are there. As the relief vehicle goes, two vehicle goes, one side towards the civilized people, another so-called tribal. The lorry goes to the tribal place of the camp. Nobody moves there until the captain of that whole Nicobari group says, yes, what is that? It is required to us or not. If required, the children will go and take first, next the woman goes, and then finally the men will go of that. Here in civilized, so-called civilized people from the mainland, as the lorry entered the camp, the people jumped on that and the army was finding it difficult to control. Then we found who is civilized, who is tribal, I could not understand. It's tribal actually. So we
I'll only add
tribal and uncivilized are not two opposite poles. That's
I'll put it this way. See, the long-term belief that many of us have had that education or urban living or Western orientation is not sophistication or civility only gets doubly confirmed in disaster situations, as Suresh said. One. Second, when you go from urban centers and qualified professionals to this disaster situation, except for the current pandemic, which is affecting all of us, generally disaster situations tends to put the affected population at a lower social ebb. And that, if you are sensitive, gets totally broken. I'm totally with Suresh on that. Let me also add this here. Like Suresh said, there are a lot of important feedback that you can use. One thing that I remember from the Gujarat earthquake, amongst many, is this couple of things. You see, there were households which had all food stuff, including water, stocked for months, if not a year or 2 years. The point that we made to the government was direct cash assistance, like Suresh said, leads to alcohol used by the men. Direct, even indirect in terms of material, only gets to hoarding or black marketing. And so what without getting into political leanings, what the Gujarat government, we noticed did in whose area, Kutch region, was our advice of generating employment. Direct assistance of cash or material only to a limited extent that is necessary. That's one part. The second, believe you me, there was the Bhuj civil hospital had been razed to the ground totally. There was no building left. Doctors and surgeons, and including one psychiatrist, Niman's DPM, in fact, of my period, Sanjeev Gupta, they all had classical obsessive symptoms. And I'm talking about 2001. this knowledge that we all are sharing today, we did not have. Nobody would enter the building of the house. They might at best go shower and come back. They might cook food, bring it out and eat. The fear of aftershock or earthquake. And we had a lot of discussion amongst our team and with our Gujarat colleagues. I don't know if anyone of them is here. Tilwani to Ajay Chavan to others. And we said, look, let's watch for a few weeks. Let's not term this as OCD and start medication. Exactly like Suresh said. In a few weeks, they all got over it. Similar thing happened in tsunami with Nambi and team. There were fishermen who would not venture into the sea. Experienced fishermen for a few weeks. The wives would not let them go. Classical phobic symptoms. In a few weeks, they became all right. So I really want to 100 times re-emphasize what Suresh said. Shekhar, his colleague, and we have kind of in NDMA said to go a step further. Not only these are normal people in abnormal situations, almost every psychological, emotional, or behavioral reaction by the affected population should be seen as a normal reaction to a grossly abnormal situation. So almost any reaction be seen as normal first before you label it. Don't give a label, don't diagnose, don't medicate too early. Let's see if there are other questions in the chat. But I really would like more of us, if we can, to connect you to the current pandemic, because unlike all other disasters, now we have all been affected individually, as persons, and we are all working in areas where there is the effect of the pandemic. So let's try and relate this presentation that we had so well to see what are our experiences in this period, like ML was trying to say, especially psychological first aid. What's our experience about PFA? Different settings.
Sir, your question is to me about the PFA here.
To you and to everybody, please, Suresh. But I'm
Okay.
also looking for the broader, but please go ahead.
Right, sir. Because I would like to combine with the one of the chat question is what to be done in such a pandemic or COVID situation.
Yeah.
Yes, because many a time in this currently we talk about the way you said, we talk about social distancing. That is a wrong word. It has to be physical distancing. Social connected should be there even virtually. Sir, I learned from you only. In the current pandemic, it is a physical distancing should be there, not social distancing. Social distancing, you can connect through people. So PFA has to be considered first because that is the way we can start a connectedness to the person. What is the requirement? How we can start work. And you will not do like you will come there and we will have a small room. No. You have to do wherever it is possible. Even if you are over the phone, it is available, talk to them. Even if it is on the Zoom call or whatever call, or else even in the, maybe in prison. Now we have one of the opportunity to work in prison. Again, the mental health in prison is becoming a problematic because they don't know what is happening with the family members outside the society. So again, we have to see how we can start providing care, start helpline within the prison department, or maybe we nowadays we have forgotten those elderly or MR homes which are there, or intellectual disability homes which are there. They are out of the radar with regard to vaccine or with regard to providing like NHRC has National Human Rights Commission. I think around 4 days back released the second amendment and also the advisory guidelines telling that vaccine should be given to all persons with mental illness. The caregiver of persons with mental illness has to be given vaccine, and if possible, engage them whatever best possible using all helpline. So that advisory has come, which is available. Dr. Rajesh Sagar and even Dr. Nimesh Desai also forwarded this, and we should now start implementing, because invariably what happens, again, one of the other best example I can give is, we say that COVID, like Dr. Sidney is now in charge of our COVID ward in Nimans, like severely ill, what Dr. Agarwal said, that we find severely manic patient. One patient within the COVID ward running around is very difficult. Now we have to find a family member who is either COVID positive and has recovered, or else who had received vaccine, or else who has lesser comorbidity, can stay with him. Is it possible? That is the model we have to start looking at, so that, because we will not have that luxury of 20-bedded COVID ward with severely mentally ill, with mania patient, schizophrenia patient, catatonia patient. We will not have the 20-bedded. We will have around 5 nurses across the it is not possible. We have to bring in a family member, if possible, who is ready to provide care. And again, if the family member person becomes ill, we should be able to provide the care in that COVID center only. We have to come out of, we have to find out of the box solution. During that time, psychological first aid is the one where we can engage either the patient family members. We have to do all possible mechanism, even use, have the connections, maybe Wi-Fi or whatever possible, so that we can connect to the family and provide care. This is, again, we have to find a COVID care with regard to, because invariably what happened was, again, this was in Nimans, one ward, there are 3 patient, 4 patient positive, segregate them, sanitize, move from one ward to another ward. What Dr. Nimesh Desai also had this problem in the, even in IBAS. It's we don't know what to do at the time. Then we've made green zone, yellow zone, contaminated zone, red zone. Again, within when the what is that? The positive rate increases by 40%. Out of 100 patients, 40 are positive, and you have a family member staying with them. We have to test them, and that family member goes out, brings food. You have to provide food to them inside the ward now. It's a huge challenge, actually, providing care. The physical related illness is different. Mental illness related, running a mental hospital in COVID situation is very difficult. And anyhow, there is a new seminar will be done by the Gujarat, our Dr. Ajay Chavan. There will be a seminar in the next week with regard to providing COVID care in mental hospital, OPD, inpatient, and community care, which will be discussed most probably. Over to you, sir.
Allow me to also add that, like Suraj said, Nimans, IBAS and a few other mental health institutions have had this experience of dealing with COVID positive persons. But also a lot of our colleagues in private and government sector, and some of us may be here, who have had direct experience in dealing with COVID ICU care, the immediate post-COVID ICU care, and the COVID ward reactions, as ML was talking about. And so I would really like, I'm sure Suresh and ML would all like, if there is more sharing. But let me also pick up from the chat what my friend Anjali Chavaria, I think, and a few other colleagues have added, which is another dimension to it. Children who have lost both parents, and Delhi High Court, Juvenile Justice Committee, by now the Supreme Court, and a lot of agencies are picking up on this. If I can only briefly answer that, having been actively involved in those activities, including today in the High Court, children who have lost both parents in this COVID pandemic, fortunately, still in our society, a lot of extended family and neighborhood for a while take care of that. 1. 2, if there are mechanisms that can be done for adoption in ethical and legal manner, wonderful. But let's not forget, child trafficking and human trafficking picks up during disasters and epidemic and pandemic situations. And so we need to be very careful about not becoming, an unwilling, unintentional party to human trafficking, including children. Childcare institutions, CCIs, is a much maligned set of institutions like the prisons, but they are not really all uniformly as terrible as some of us seem to believe from Charles Dickens. A lot of CCI reform is happening, and so if you don't have a choice, CCI with supervision and monitoring of the agencies like CWC will be the other answer. But I would really like, if there are in the chat, or I'm sure the host, Dr. Tufan Pati, Dr. Alim Siddiqui, and Dr. Amrit Patijoshi would like you to show up on the video, unmute yourself, share experiences, please.
Sure, sir.
Because this is one pandemic we've all been involved. I mean, please, Alim.
Yeah. Thank you, sir. First, congrats to Suresh boss. It was like we were going to the camp with him in real life. So
Not you. You are not fit enough, Alim.
That's Suresh boss has said. Amrit is fit and other is not fit. So that is noted. So the question was repeatedly in the chat box is survivor's guilt and how to deal with it. Many people have posted it. So any 4-5 points that you would like to tell?
Okay. Yeah. See this again. Yeah, we had done this in survival guilt. I gave an example of that person who was drinking alcohol and had difficulty in accepting because he was going through shock, denial, and anger. He was angry. He was in the. If you look at the grief, the Kubler-Ross grief cycle, he was First one, shock, denial, and anger. He has anger towards himself, telling that I was not responsible to take care of my wife and child, they died. So now we have to sit with him, engage him, and talk to him, maybe a psychological first aid. And rather than focusing on alcohol, what is the loss he had? And then start validating his emotion. If I'm in your place, I'll go through the same thing. If I'm in your situation, if I was there, same thing would have happened. We are not Superman, or you are not a Superman that you will go and rescue your wife or your child. It's simply impossible. The disaster equals everyone, even if it is a doctor, even if it is maybe a MLA, or even a poor person on the land, it will equal. So engaging him, talking to them, validating their emotion, that yes, anybody in your situation will go through the same. Even if I am in your place, same thing up. It will take over a period of maybe 10 session or 5 session, because in the disaster, you may not get that opportunity to engage him next time, because today I sat with him, I spoke to him. Again, he will be available tomorrow in the same camp because nobody is there for him. So if possible, engage him for 1.5 hours, talk to him. Because tomorrow I may be not there in the camp, I'll be shifted to some other camp, or he may be shifted to some other camp. Possible, if possible, what we call cognitive restructuring, even in one session possible, do it. Because luxury of having that he will be available tomorrow, day after tomorrow, it's simply impossible. Start talking to him, see who is the friend available, tell him this is the way to talk to him, and then engage him. And if possible, you meet him tomorrow, again engage him, and again try to validate his emotion, do it. But with regard to children, it is very difficult. Even if you look at Andaman Nicobar in 2004, there was no orphanage. The reason being is, if there is a child who did not have parents, the Nicobari tribals used to just adopt them. No questions, nobody asked. He belongs to the tribe. That is the way they had. Now the orphanage came because many people went there, settling there for tourism. Otherwise, there was no orphanage. They adopted them without any questions asked. That was the beauty of that place at that time. But now again, what sir mentioned about the, again, this is again which came in newspaper in the middle of the night, 2 o'clock. A child was brought from one of the island. The child was on the top of the coconut tree for 4 days. Imagine, 4 days, no family member, we don't know anything. The child is hardly around 8-year-old. It was brought, and 2 o'clock they knocked the door, police, everybody came, and they said, sir, we got this child. We don't know what to do. We sat in front of the child talking. The child did not open mouth for nearly 1.5 to 2 hours. The child was in utter shock. I was there, Dr. Satish Girimaji sir was there. Our 6 team members trying to talk to the child. Imagine, I can't, I never had this experience, neither Dr. Satish Girimaji, Dr. Vivek Benegal. We were shocked, and the whole, we were sitting there and trying to talk to the child. Imagine. And the child was completely numb, no emotion, nothing. And having numbness.
Did we lose again?
I think
Yes, sir, I'm back again. So having, as per the current researcher, having numbness is an indication for PTSD in the future. So I'll stop there. Go ahead, sir, please.
Let me
Dr. Suresh, one minute. Dr. Suresh,
Yes.
ML, please.
with due apology, one comment.
Please, sir.
In one slide, you were training the NGO persons and in the tsunami or there. But in my opinion, that looks to me like digging a well after fire. You are the from top institution of the country. You should plan in advance to give training to NGO persons and doctors and psychologists and general health workers. You should plan in a broader way. You have funds, you have the government resources. I served as a divisional president of Rajasthan Bharat Scout Guides 10 years back for 9 years. At that time, I trained all the officers of the Scout and Guides, mental health and disaster, and give a booklet to them, prepare a booklet and give them all things you covered. I told them. So you are from big institution. I accept more from you. You should plan and give proposal to Government of India.
Yes, sir.
And we are
Sir.
in periphery. We are here to work.
Suresh.
Yes, sir. Please go ahead, sir. Nimesh, sir.
See, ML.
Yeah.
in fairness to not only Suresh but Nemaz also, he is talking about 2004 tsunami in Port Blair. Okay,
Yeah.
everybody has learned lessons.
No, no,
Shekhar, my friend.
I appreciate his work. That's why I am telling him.
It's serious matter. See, Nemaz and a lot of other agencies, like you are describing, post Gujarat earthquake and tsunami, have started doing that preventive work.
Yeah.
So let's face that it happens. I know of your work, but let me say this about children, Suresh and others. I really would like more of our colleagues to participate. See, one thing that we have found in all disaster and conflict situations, including the Gujarat riots, that I had the good fortune or bad fortune to work in. Playroom techniques, play techniques, draw person test.
Yeah.
Those are the things that will work. And I'm sure Suresh will agree. When Alim, people keep asking about survival guilt and everything else, I have one thing to say briefly, but to the point. I have realized in all conflict, disaster, and now epidemic situations that if ever there is a time in our career where listening skills are important, it is the conflict zones and the disaster situations. All kinds of listening skills, including attentive and reflective listening, like Suresh was saying. I mean, you just sit wherever at the street corner with that person who has survivor guilt, who has been through trauma, and let it flow with everything else that Suresh said. So, to me, most important thing to remember and be able to practice would be listening skills within reasonable limits, including physical touch. It matters a whole lot. Allow me to also touch upon something else that Suresh said that I really resonated with me. I remember in Gujarat earthquake, I was individually and all my teammates were initially very surprised, as Suresh said, by design, by administrative order, or by spontaneous behavior. We saw camps organized along not only religious groups, but within Hindus, Banyas, Brahmins, the Kshatriyas, and the pseudo-egalitarian that we are, and certainly 20 years ago that I was, initially our thought was, why should it be like this? Let everybody mix everywhere. And then I realized within a few days that what was happening was actually best. At the time of disasters, people require to be with people who they identify with. And so this, with again, no political meaning, pseudo-secular, pseudo-egalitarian nonsense must be thrown out. We, in fact, in our report, call it social identity groups. People feel comfortable, not the organizers want it that way. See, Aga Khan people want a set of people of a certain band. One group wants the Banyas of a certain region of Gujarat. So a lot of other things, like Suresh said, we need to really drop all that baggage if you want to be effective, including being actually merely a relief worker.
Yes, sir.
You are not even a specialist mental health worker there. You are a relief worker who happens to carry mental health expertise also.
Sir,
But let's see, there are more questions in the chat. Yes, Suresh.
Sir, one more. Agarwal sir made a point. I would like to respond to that, sir. Sir, okay. How many of our MD psychiatry students have been trained in disaster? It is simply impossible. See, I did my MD in Nimans. I did my senior residency in Nimans. I was never taught unless I worked in disaster. You will never learn, sir. Right. After that, after the tsunami only, the disaster mental health came into DMHP. Still, unless you work in disaster, you will not be able to know what is there.
One
and not only that, sir, second point I'll say, sir, our own, sorry to say this, our own Indian Psychiatric Society becomes enemy, telling that how can you allow MBBS doctor to write this medicine? How can he write Respirodon? How can he write? So this kind of attitude should stop. First, second one is train all MBBS doctor in psychological first aid. They should be able to give medicines in disaster. That should be the way to go, sir. Unfortunately, our professionalism has killed our humanity, if you ask me. Sorry to be very ruthless.
Agarwal, sir.
I will like to highlight to you when I did the MD, I passed MD in 1978. I retired in 99. And now I am 78. So these things are very new. But if interest is there, one should be in touch with the latest studies.
Yes, sir. Yes.
Yes, sir. Very
Latest
much.
work.
ML, you are great
Yeah.
in that. Can I put in one word before I really want to? Suresh, I'm sure you'll agree. What I have learned in the 90s and in this last 2 decades is what you and I and ML are all saying. Let's enter a disaster or a conflict zone or even an helping situation with a normalcy paradigm. I want to see everything through the normality lens, not with my psychiatry lens, not
Yeah.
DSL.
Yeah.
You know,
Yes, sir.
normalcy paradigm is perhaps the overriding principle. Is there, let me see if there are more questions in the chat box.
Yeah.
I'm sure Alim or Amrit are also monitoring.
Yeah, Amrit wants to ask something, I mean.
Sir, please, Amrit.
Amrit.
Sir, I think the whole pandemic has been a lesson in disaster management. If we tell that we have not experienced disaster, then nothing bigger than the disaster we are facing now. That is why we had actually Suresh to here, somebody who's experienced, and it will be a little dynamic thing. You know, the most important thing is a tsunami comes and goes away, sir. It's there for 2 hours, 4 hours, 6 hours, 12 hours. But this tsunami, you know, the first tsunami was maybe 4 months, 6 months, but this has been horrible, sir. You know, the number of deaths, the children being orphaned, we as doctors, you know, bereaved, grieving. And the most important thing is motivating our own brothers and sisters. And I mean our students who have just fresh pass out, and we push them to the ICUs. You know, doctors are being COVID positive, they're in quarantine, they are losing people. And we have opened so many centers. You know, the center is telling that we have 31,000 beds. We have pushed our young people who had hope, who thought that we are saviors, to look. And the worst part about this pandemic, this time, second wave, has been 30. You know, today I was checking our state. Out of 42 deaths, the average age of death was 33 years. The average, I made an average, it's just 33. And it's how to manage their family members. You know, then, you know, young people, the lungs are gone. Everything else is holding on.
Yeah, yeah.
How to tell them that they're not going to survive? We sell them the ideas of ECMO, lung transplant. You know, that's the whole disaster. I have to motivate a set of young people every day to go to work. That will be go to do a death set. We write death certificates, sir. They're crying. So how to do that? That's the most important thing. And pandemic, you know, it goes in 4 hours, and we cannot tell that tomorrow is going to be a good day. You know, today I got a news report that 24,000 children are you know, having COVID in Vijayanagaram and Vizag. So the most uncertain thing is my kid. If something happens, what will happen? I don't have the vaccine. We are not equipped. We don't know what works. Today somebody tells Remdesivir works. Tomorrow somebody tells Thali works. Day after tomorrow somebody will tell that, you know, fluvoxamine works. So we are all uncertain. We know that nothing is working. So that's the most important disaster, and that's why I think we pulled Suresh here to make us understand how we can go get it going in a better manner. Suresh, your take.
Disaster, in every disaster, chaos is the norm. Accept it and work in the chaos. That is the way it is.
It's not, the chaos should not be this prolonged. It's a year now.
Amrit, can I also say that you put it very well, and like Suresh is also saying, chaos is not the trouble or the advantage. I think advantage is that till now all disaster and conflict situations, whether we liked it or not, was we versus them, or at least we and them. Them was the affected people, we were trying to help. This pandemic has merged all of us as one. There is no we now. We are all them.
Together. We are in the same boat.
Universalization of that disaster experience is so true, especially with the second wave. And like you said, I mean, people are also saying in the chat box, yes, seeing young doctors die, seeing kids orphaned is a terrible experience. But I am with Suresh. Chaos is the norm. I really do think that even in the second wave, all the hype about what I did.
Sir, and the best part, Alim, I'll just add one line.
Yes.
Sir, Odisha government has added disaster management as a topic in the 10th and plus 2 education, the school education system this time. 3 days.
I remember that. Correct, sir.
That's a bold step.
Let me add a question here from the chat box. How should we as a mental health professionals help in taking care of mental health of other medical professionals?
That's it.
Suresh, please go first.
Any
s-
ideas on how to go about it?
Yeah, actually, see, one is IMA and also Karnataka Psychiatry branch started a helpline for all doctors and healthcare workers. So we have to liaison with their group only. Basically, if we are going to provide helpline for nurses, liaison with the nursing council or nursing group association, start helping them, and we have to empower them and handhold them so that they provide their what we call it a stress management or resilience building, those to be planned, and we have to, that is the way we can move forward. At present in Karnataka, IPS Karnataka along with NIMANS and IMA, they are having a helpline for all doctors. Dr. Jagdisha is in charge. We are getting around 8 to 10 calls per day at this point of time. Most of the time it will be either alcohol related or maybe some family member died. So these are the issues we are discussing. So that is the way, one way we can go ahead. And also if we are in a medical college, have a maybe stress management program or discussion about the issues or debriefing with the team is very essential. If like I'm head of unit 5, I have to see what is happening with the JR, what is happening with the SR, have weekly one Zoom meeting with the whole team member. That is very essential because they're also going through the chaos what Amrut is telling. They'll say, I don't know, sir, what happened. I did this. Okay, very good, you did this. Validate their emotions. Sir, I was having panic attacks. So, I am also in PPA. I also have same thing. So they're looking at somebody as a leader. So you have to validate their emotion. Even I also having panic attack, but I should validate their emotion, carry the team together. That is the best way to deal. So having connection, keeping in touch with them and running with them is very essential. Sometimes you have to lead before they go. That is the best way to deal. That is my answer, sir. Nimesh, sir.
Sharing is
as
caring.
an institute leader.
Sharing is caring. Encourage sharing in whatever form. But one Dr. Mustafa said in the chat box, Suresh, and I'm just going to mention that as he said, and then we come to the point. He said spiritual counseling should be a part. My point is, for wherever required spiritual counseling, inverted commas, sure, but the issues of spiritual faith and socio-cultural belief system, that is what we need to encourage. Suresh, more, please.
Sir, this is again a spiritual related. We had to face in Andaman Nicobar Islands because Port Blair was allowed to come for all volunteer agencies. Volunteer agencies who came with the baggage. Some people said we will give spiritual one discussion, another came with another one. There was a communal clash is going to happen there. This was a big headache. The administration was very nervous. So then they started keeping, okay, you are religious, you come later. If you are this, you come later. But that is the biggest problem, sir, that spirituality is good. I'm not telling that. But when they go, they aggressively they go. That is the biggest problem. I find it very difficult to advocate at the early part of the disaster. In the disillusionment phase, when there is almost settled, yes, spirituality may play a role. But in the early part of the disaster, no. I would rather say I will keep my finger crossed. If they go with the baggage, come here, this is the person who's going to save you, this God is going to save you, or that's going to create a trouble in the what we call it as volatile situation, sir. That is my response.
One of our friends on the chat box has a very important question. I'm sure we'll agree. What about the void in rituals after loss? We all know that when we have lost friends, and void in the rituals following the loss of a loved one. And so that genuinely is one question in the current situation, because you are not able to do any of the rituals immediate or over weeks. So are there thoughts on that? I agree, it's a very important issue, and virtual rituals, so there's only one answer. One will have to learn to live with it.
Yeah.
But it is a real problem, sure. I think that was Dr. Shubhangi Agarwal. Dr. Shubhangi Agarwal raised that.
Yeah.
I have. Can I take the liberty? I have one of my very long-time friends from Delhi, very active behavioral pediatrician, Dr. Kiran Agarwal. I don't know if she is still here. If Dr. Kiran Agarwal is here, I would really like. She did put one or two questions in the chat box. If you'll allow Dr. Kiran Agarwal to unmute and share, because she is one of the pediatrics colleagues who I have known for more than 20 or 25 years. being involved in developmental and behavioral pediatrics and child and adolescent health and mental health. Kiranji? Okay, we seem to have lost her. Sir, you must guide us. Dr.
Sir,
Tufan Pati, Dr.
I
Ali
will,
Mehdi. Sir,
Dr. Desai,
Abalo.
this is very true. This is one of the factor affecting the mental health of the persons, not performing rituals, not proper disposal of the body of the loved ones. This is the according to our Indian culture. For that, I sponsored a program of started today from 4 to 7 of Disha 10 Tata Sky 1058. So homage to the those persons and to manage the stress of the survivors. So that if you know Mahabharat Katha jo karte Bhagavad Katha is performing there. People are enjoying making stress management there virtually. That is the virtual program. And 4 to 7, 3rd of June to 8th June, anybody can watch there and listen there. So survivors can manage their stress. I believe it. That will affect, that will relieve their divert their attention, and they will feel. And there is always Shraddhanjali by the Saint Jo Mahamandaleshwar. They give the Shraddhanjali to all those left in the on the earth. They pray for them.
Yeah.
Right.
So back to the current pandemic, I think this issue of isolation. Suppose if someone is admitted in the ward, he's isolated.
This is the virtual program on TV.
Yeah.
You can watch on TV. This is
Sure.
1058
Sure.
Disha.
Sure.
It is a religious channel.
Sure, sir. Thank you, sir. I was talking of another matter. In
Yeah.
this patient, suppose he gets COVID and admitted. So ward is isolation. ICU is definitely fully isolation.
Yeah.
So what sort of mental health issues are you guys getting out of this special isolation that is added to the adding to the injury?
That's what Alim. So I think we need to change the protocol. Considering if we are having a COVID, see, Dr. Mahesh had a discussion, Dr. Mahesh Spandana Nursing Home had a discussion with him. What he is doing is now he is allowing family members to be with them. Considering, okay, there is a problem because they are taking care of mental ill. So to mental ill case, he doesn't have so much of staff to look after each individually. So he's allowing family member who they have calibrated the risk. Okay, risk come, you can stay with them. So they also ensure if you have problem with COVID, we will try to take care of you also. So I think somewhere down the line, we have to assess the risk. If there is a pre-existing mental illness, there is a risk of high morbidity, then we have to allow family members to be there, connect with them. I don't know how it has to be done. We have to do it, because complete isolation, I don't know, it will be bad for mental health, both for the survivors left behind and also to the person who is there isolated.
I agree with you, but let's also be sure. I agree with you. See, complete isolation was the norm in the mid and late 2020. By now, after the second wave, when we are on the brink of herd immunity, what Mahesh and you discussed is viable. Today,
Right,
we
sir.
have done that. One of my senior officers' mother-in-law is admitted to our transit COVID facility, and we have said, let somebody be with her, dementia, with gross behavioral problems. So I am with you, but that is also the phase of the epidemic, my friend.
Yes,
You
sir.
agree?
True,
Sir?
true, sir, true.
So I'm with you. Now we need to change it now. But Alim bhai, you must guide us about the time, please, you and Amrit. Huh? Because Suresh and I will go on.
True, sir, true.
We are nearing time. We are nearing the end of the time. If sir,
Okay,
you allow,
okay.
we can have a few minutes more.
Okay. Can I just say two things at the end?
Can I, sir, there is
Amrit, bolo.
one Aditi who has put a in the
I
chat
know
box.
Aditi said very good comments. Yeah.
Hi, Dr. Amrit. Can I mention a training on trauma-informed interventions and care here? So we can unmute her. Let her speak for 2 minutes, and then maybe I'll hand it over to her. She has worked in floods in Kerala also, I think. So
Sure.
You know,
So,
I saw her comment.
Aditi
I
can
wish
raise
Aditi
her
can come
hand.
on.
So we can identify
Aditi,
her.
please raise your hands.
Aditi,
We'll unmute.
can you raise your hand so we can identify you?
Take it.
Yeah, I'm unmuting you. Yeah, please.
Yeah, and thank you so much for the talk today and the discussion. I'm a psychologist. I work in Pune, and I've been working in trauma field for a while. I'm for mental health workers in India. I'm organizing a 4-part series on trauma-informed interventions and care. This is being done by Naomi Halpern from Australia. So I just, if it's okay, I'll just post the link here for the YouTube channel.
Please, please.
Okay, thank
Many
you so
thanks,
much.
Aditi.
Yeah, thank
Many
you so
thanks.
much. And
Many thanks.
I think Dr. Kiran is also online now.
I know she sent a message. Kiranji, please.
Yeah, thank you. Thanks for the wonderful presentation and discussion. I attended an international disaster management course years back, and I really feel very bad about it that we are being in Delhi, we are in seismic 4 zone, but there is no training even to the school children. Hello?
Yes, please go on.
Yeah. So I was really interested in if we can have some basic training for the school children on disaster management in case of natural calamity.
Kiranji, modules are available. It's just a question of implementing them. Ho jayega.
Yeah, yeah.
Ho sakta hai. You're right. But
It has been decided to be implemented in Odisha already.
Exactly, like Amrish said. Like Amrish said. Correct, sir.
Yeah,
Right.
yeah.
So
Yeah, I'll connect with
gradually states will take up because it needs a policy decision. It will be done.
Yeah, yeah.
Thank you. Thank you.
Allow me to say these two things at the end, Tufan, Alim, and Ambed. Like Suresh alluded to quite a bit. Let me put it out in as many clear words as I can. Of course, accepting what Amrit was saying about this being an ongoing, cumulative, and collective disaster, the current pandemic. But the learning till now is this: adaptation and resilience play a huge role in less mental health morbidity, especially in Indian and South Asian culture. To my mind, there is very strong evidence about cross-cultural differences in favor of Asian and African culture for mental health morbidity, short-term and long-term being less. PTSD, near zero. Some of you will remember our 2017 award-winning Marfakia paper was Gujarat earthquake, 35,000 population followed up for 8 to 9 years. No
Yes.
PTSD.
Sir, that is striking.
Called the myth of PTSD.
Sir, actually,
so that's one very, very positive news. And so in line with what Suresh said, let's go there as health workers, as relief workers with expertise in mental health, go with the normalcy paradigm, work as human beings rather than specialists. I will stop there. And like Suresh said, 12th June is the symposium Saturday afternoon on mental health institutions. 19th afternoon is the Manthan on PTSD.
okay, sir.
So just tune in if you like. Thanks so much, guys. Organizer, thanks, Suresh. Great.
Thank you, sir. Thank you, sir.
If Dr. ML Agarwal has any words for us? ML, sir?
Yeah.
Agarwal, sir, please.
Dr. Suresh presented a wonderful presentation and practical experience, especially not theoretical experience. So I thanks you and hope with you to spare some time to give training to my area also. So
definitely, sir. I'll be with you.
With this hope, I thanks to you, Tufan Pati, Dr. Nimesh, and all the persons participated in this. Thank you.
ML, I like the photo behind you with Bhaviji.
Tufan sir, your comment,
I'm a drawing room.
So thank you everybody Thank you, Suresh, for a nice presentation and sharing your experiences. And we belong to Odisha, which is a very favorite place of many disasters. If you consider floods, and maybe we have every year some disaster, flood, cyclone, we are. And I have got a lot of experience in working in 1999 super cyclone over 2 years. I don't want to share those things, but I want to make a difference in those disasters and the current situation. In those disasters, it lasts for a few days, then it is over. And anyone who is a survivor, they remain connected. Now what is being impaired, which are presenting here as isolation, or that is you are losing real connectedness. And if one argues that we are having telephones, mobile phones are spread that so much, actually it is not so much. Smartphone users in India are around 50%, and that is smartphones users by a number. But I am having 3 phones, Alim is having 10 phones, Amrit is having 15 phones, Suresh may be having a dozen phones. So the real number is low. So connectedness in terms of mobile phone is not easy, not the fact. So what we have to do, we have to reach out and make connectedness, involve connectedness, as it was rightly pointed out by Suresh Badamat. Mental health morbidity is one aspect. Maintaining mental health is another aspect. And we may not have to use pharmacological things, but you have to increase resilience and increase connectedness among the people. That is the most important challenge before mental health professionals, before the administration, and everyone who is dealing with the mental health aspect of this pandemic related disaster. And I thank everybody, Nimesh, Dr. Agarwal, and Dr. Suresh for this nice evening and the wise inputs. I don't want to prolong because we are already ahead of time. And thank you, and over to Amit.
Thank you, sir. We had a wonderful Suresh, as always, dynamic man. Chick, beautiful background, always well suited, gelled hair, and his oratory skills is matchable. So thank you, Suresh. You live is much more, so much better than the video version. No, that's why we wanted you live. Thank you so much. It was wonderful, and we called you, and within 5 days you came. Nimesh sir and Agarwal sir, they were equal to the task, or more than equal. They complemented, and maybe they added to whatever Suresh spoke about. Thank you so much, sir. You are wonderful chairpersons, and for a change, Alim was quiet, and that was a very important aspect of today's discussion, sir. Thank you, Tufan sir, as always, guiding us, helping us. Our team, Torrent, IPS Odisha State Branch. I hope we can carry forward whatever we have learned to the disaster that we might have a psychological disaster that we might face in the coming days, and that will be a very, very tough one. Dealing with your own grief as well as trying to deal with others' grief is one very, very difficult task. And as Dr. Suresh told, that we have to empower others also. We cannot just think that we are sitting over a kingdom and everything is ours. The more better generals you have, the better king you are. That's what I always believe in. So, helping our MBBS doctors to understand, and everybody should get their share of psychological help. So that's what I like. The best part about Suresh's presentation was that we have to empower our own juniors, our own students, everybody who can do a good job. You need not have a degree to help people. That's what we should learn. Thank you, everybody. Next week we have another wonderful presentation. I hope you all will join us. We had a very good attendance today, maybe more than 300 logins, and that's wonderful. And that I think Alim
Thank you,
should take credit. Alim should get the credit for all these things. He's our TRP head. Thank you so much. Good night. Have a wonderful weekend.
Thank you.
Good night, everybody.
Suresh boss.